Hey guys, Don here. Welcome to Podiatry Practice Mastery. Going to go over the $1 Million Minute, trying to give you kind of the things that I'm thinking about and working to get my practice to the $1 million mark and beyond. So today what was on my mind is we were doing negotiations with Athena and ModMed, and I want to kind of just share it if you're considering switching EMRs. We had kind of a long experience with EMRs. We used to have MediNotes, then we switched to Litech MD, and then we switched to Athena. And now we're thinking about switching to ModMed. So the way we did it, I tried to make it a little bit more objective than subjective because it takes a lot of stress, and everyone has different offers and what say they can do certain things and this and that. It just gets a little confusing. So what I did is I made a little spreadsheet on Excel. It was pretty easy to do. I put in the total revenue amount that we're going to produce this year, which is a little over 3 million, like 3.5, maybe 3.6 million for 4 doctors. Then I put in the amount of cash, so cash payments, and then I put in kind of like what are the expenses. So when I'm evaluating both of these EMRs, ModMed, they have like a monthly fee, which is like $1,000 a month per doctor, which is going to be about $48,000. And then they have a percentage rate, which is for their program or the billing. So for each of them, we're going to use their billing systems. The issue is Athena has a higher billing system or higher billing percentage, and they charge for cash payment like Shockwave and things like that. And so our qualm is, well, they're not doing any work for that cash payment. They shouldn't be getting that, but they're not really willing to budge and carve out the cash. ModMed, the way they do it is they charge you for the system per month, so that's the $1,000 per doctor per month. And then, so the cash stuff they don't charge you for, and then they just charge what you're billing through the insurance. So that's kind of the idea. So we're trying to work on the percentages. I made a little spreadsheet. If it would help you, just send me an email, don@podiatrypracticemastery.com. I will send that to you so you can take a look at that. But that's what's kind of been on my mind lately, and I'm working on that. And we had a call. Athena kind of went down, and then now ModMed, we said, hey, could you either go down with your percentage or reduce the amount from like $1,000 per month to $800 per month? Because we're wanting the delta, because the delta right now, or the difference between ModMed and Athena, as we're doing the calculations right now, including all the add-ons. Now, this is another thing you have to remember. We have a lot of add-ons with Athena. Like they have a chat bot that we add on to Athena. It's called OMD. We have to pay for that. We have the iPad thingies that we pay for, so that's an add-on. So you have to include all these other add-ons as well as your monthly expenses, so you can really compare apples to apples. And so we're kind of working with them, and I'll kind of keep you informed kind of what's going on with that right now. But they want to finish things before the end of November, so I'll let you know what we kind of decide. It's going to be a pain anyway. I'd prefer to stay with Athena just because of that, but if the delta's not worth it, and then going forward, the delta might be bigger because of if we do more and more cash payment. So it would be actually maybe more beneficial. But the big groups like Balance Health and things like that, they tend to use either Athena or ModMed. So if you're on either one of those, you're probably okay. Okay, let's get into the day. Kind of an odd day, and I'm gonna preface that because I am not a dude. I don't do a ton of amnio. If you've been listening to these for a while, but I had 2 today, and some people brought in some thoughts, saying, oh yeah, they're not FDA approved, and what do you say when patients question you on that? I've never really had a patient question me on that, but I use the ViaFlow, the right half cc, and I reconstitute it. You can do it 3-to-1, so I use 1 cc of saline, and then I add a half cc of Marcaine in there, and that's kind of how I do it. So I had 2 of those today. I'm going to first talk about my MVP patients. I had 2, once again, not that common. The way I do it is I tend to explain the whole process, and then I usually schedule it on the second EPAT. So the first one was a 48-year-old guy. He had a kind of a 5th metatarsal head bursitis that's been there for years and years. He's tried tons of stuff. And so I did an EPAT number 2. He's already feeling better. And then afterwards I did the amniotic injection in there with ultrasound guidance. And then he asked me about the nail fungus, and so I went over my whole nail fungus process with the UV light and the shoe spray and the terbinafine. So that gave me the office visit. And this guy is all cash pay. All cash pay. So he came because he doesn't have insurance. Not many of those around here in Massachusetts, but that was one. The second MVP was another patient. She's a 55-year-old female. She has a painful second metatarsal head with a plantar, kind of a plantar plate, kind of tear that's just been there for a long, long time. The pain is a little bit out of proportion. And all the other doctors wanted to do was do a plantar plate repair with a wile, and I kind of gave her this option. She's on EPAT number 2, and we did an amnio injection right in that area. So I could find right exactly where the plantar plate was inserting, at the base of the second digit, and I injected right in there. And I put her in a walking boot, and this other guy, he had a surgical shoe. So those are the two MVPs of the day. So those really are good patients. Other patient that came in was a gentleman, status post exostectomy. So he had an exostectomy between the fourth and fifth toes. That was an office procedure. It's one of my favorite ones. We got x-rays just to show him that. And then he had EPAT number 1. He had second metatarsal head metatarsalgia. So we started those. There's another 2 coming up. Another patient that came in, he hasn't been here for a while, and he did a diabetic foot exam, and I'll see him back in a year. Did some calluses on him. There was another patient that came in for a porokeratoma, and I treated her. And this is an instance where my patients get x-rays in everyone. So there was an x-ray, even though it's a skin lesion, everything that's painful, they get x-rays. So it's just a way to think about it. Even if it's a painful poro or a painful callus, if there's a bony prominence under that, you can show them with the x-rays. So they did get x-rays. Another patient came in for a brace modification, and thankfully I couldn't do the brace because of their insurance. I had to send them out to Hanger, so I told Hanger to take care of the brace modification. This was like a Ritchie type of a brace. Then there's another patient came in for he had a new BKA on the left, and he had kind of a cavus foot on the right and needed an orthotic. So I did one orthotic, and I didn't realize this, but with my lab, when I only scanned for one foot, they only charged me for one orthotic. So I gave him it for half the price because he doesn't need the one on the other side. And then I debrided the ulcer, and I'll follow him up on that ulcer. He has an ulcer on the foot that he has on the right side. Another patient that came in for ingrown toenail, so I did an IND on him. No follow-up. Another patient that came in for EPAT, once again, second metatarsal head. And another patient that came in for a possible painful callus. It ended up being a wart, and my staff got an x-ray. Similar thing, painful calluses, painful warts. My staff don't really know the difference. They just know it's pain, and so they'll get x-rays for those patients. And he got the 5FU I give with that, and he did the CAD and thread in. I talked to him about Swift, but he declined. Another patient that came in after 3 EPATs, 6-week follow-up, was about 80% better. So what I do now is if they're about 80% better, I don't do more shockwave. I double the time. So instead of 6 weeks, I see them back in 12 weeks. So it's a 3-month follow-up for see how they're doing with the EPAT. Another patient came in, had a cortisone number 2. So this patient, you can see I don't do much cortisone, but this patient, they did well with a plantar fascial cortisone injection about 6 weeks ago. Then they went to PT. And I did another cortisone. I did it with ultrasound, so it was really, really thick. I think she's going to benefit more with shockwave to get down that thickness of the fascia, but she opted not. And so I did the cortisone, and I spaced it out for 12 weeks is when I'll see her back. So I tend to, patients that, how do you say it nicely, that kind of don't take my recommendations for shockwave or what I really think is going to work, I space them out a lot longer. So I'm seeing her, the first one was 6 weeks, and I'll double it to 12 weeks. And then we'll see how she's doing when she comes back. Another patient came in with lateral foot pain. I've had some patients recently that have had this. They've had kind of lateral kind of foot pain, and it tends to be from the equinus, the really, really bad equinus they have. And so this one got the night splint, the Pelto special. I got x-rays, and then I'll see them back after they're working on that. Another patient came in for shockwave to the posterior tibial tendon, had kind of a tendinitis. This is EPAT number 2. Another new patient that came in because he had shin splints, and once again, he had equinus, got foam roller, splint. I recommended EPAT, but he's at college, so he's going to be going away, so I recommended he get shockwave somewhere else because I think that would really benefit him. And we also scanned him for orthotics for his foot. And then there was also another patient that came in, a new patient came in for posterior tibial tendinitis. They also had equinus, so they got, I gave some compression around a sleeve and then help for the equinus. Another was a Lamisil booster, which is what I do after they've taken the first 3 months. I give them another booster, then I'm not seeing that one back. And there was a fifth toe fracture that came in. They had it for 4 weeks. They just wanted some reassurance. I'm not going to follow up with this patient, but I did get the fracture code. And then another patient that came in from bilateral balance brace dispensing. So when I dispense these, I have to see the patients. So I dispensed it, and then I'll do a 6-week follow-up. Mentioned they got that was when I could build the bilateral balance braces. And then there's also a follow-up fracture after an MRI. This is a patient, she had a fracture with another doctor, and then it was doing fine, but then it refractured because she was very active. Then I did shockwave on her, and she was just kind of concerned. And she has some reduced fat pad, and without having a cortisone, but just some reduced fat pad. She's an older woman, about 81. But she's doing better now, but she was just concerned, so I reviewed her MRI, and she already has orthotics. And the main issue is she's trying to get in some other cuter shoes because she's kind of a social, she likes her social life, and so wearing those other shoes were hurting her, and I just said, well, I gave her a Dr. Jill's metatarsal ball of foot pad, and I say, if we wear those other cute shoes, wear this little pad, this might make it feel better because her orthotics won't fit in there. Anyway, that's the $1 Million Minute. Once again, send me any of your thoughts. Thanks for participating in this. If you like it, share it with other people so they can get the benefit from this, and I hope you get to the $1 million mark soon. Thanks.